Low birth weight baby. Introduction. A neonate with a birth weight of less than 2500 gram, irrespective of the gestational age, are termed as low birth weight baby. They include both preterm and small for date babies. These two groups have different clinical problem and prognosis. In India, about 30 to 40% neonates are born low birth weight. The low birth weight are more prone to malnutrition, infection, neurodevelopment, handicap condition. Approximately 80% of all neonate deaths and 50% of infant death are related to low birth weight babies. So this is the introduction of low birth weight baby. Now we will see about the definition of low birth weight babies. According to Piyush Gupta, low birth weight are defined as the babies born weighing but 5 pounds, and they are at increased risk for serious health issues as newborn, lasting disabilities, and even death. Next is, according to WHO, babies with a birth weight less than 2500 gram, regardless of gestational age, below 10 percentile, is known as low birth weight babies. Now we will see the types of low birth weight babies. First type is very low birth weight babies. Babies with a birth weight of less than 1500 gram or 1.5 kg. Second type is extremely low birth weight babies. Babies with a birth weight less than 1000 gram. Then third is small for date low birth weight babies. That is babies with a birth weight less than 10 percentile for their gestational age or less than 2500 gram, that is 2.5 kg. So these all are the types of low birth weight babies. Now we will see the etiology of low birth weight. First is maternal history. Second is maternal malnutrition. Then intrauterine infection, placental disinfection, twin pregnancy, maternal diseases, genetic or chromosomal disorder. These all are the etiology. Now we will see the care of low birth weight babies. Depends upon birth weight. 2500 grams to 2000 gram requires special care at home. Less than 2000 gram requires special care at hospital. Less than 2000 gram and requires kangaroo mother care. Greater than 1800 gram are stable. Now we will see special care at home. Its principle: prevention of infection, prevention of hypothermia, correction of malnutrition. We have to prevent from the infection to the baby, from the hypothermia, and we have to provide the baby proper feeding to prevent from the malnutrition. Now we will see the special care at hospital. First is prevention of infections. Second is prevention of hypothermia. Next is correction of malnutrition. If the baby is not feeding properly, then we have to provide NG tube feeding to the baby and maintain the temperature of the body of the baby. Next, we will learn about the kangaroo mother care. It refers to the care of preterm or low birth weight infants by placing the infant in skin to skin contact with the mother or any other caregiver. Prevention of KMC. Baby must be stability dressed in a cap, socks, and an open shirt to have skin to skin contact between mother and babies. Next, we will see about the benefits of the KMC. Benefit of KMC to the baby. Baby is kept all the 24 hours by the mother. It has minimum risk of apnea. It gains physiological stability. It gets safety and love. Early growth is promoted. Next is benefit to mother. Mother is relaxed, confident. Bonding stabilizes better. Breastfeeding become successful. So these all are the benefits of KMC to the mother as well as the baby. Next is pathophysiology. Due to any etiological factor, maternal or uteroplacental transfer of oxygen and nutrients of fetus is decreased. This causes a reduction in the fetus stores of glycogen and lipids, leads to hypoglycemia at birth. Polycythemia can occur secondary to increased erythropoietin production caused by the chronic hypoxemia. Hypothermia, leukopenia, hypocalcemia, and pulmonary hemorrhage are often result of low birth weight. Next is clinical manifestation: fetal hypoxia and intrapartum death, severe birth asphyxia, meconium aspiration syndrome, congenital malformation, symptomatic hypoglycemia, and hypocalcemia, inappropriate thermoregulation, hyperbilirubinemia, pulmonary hemorrhage, polycythemia, poor growth potential, development of diabetes mellitus, hypertension, and coronary artery disease in adult life. These all are the clinical manifestation. Then next is diagnostic evaluation. First is ultrasound. Next is Doppler flow. Third is weight checkups. Maintain the weight of the baby. Fetal monitoring. Then amniocentesis. Next, we'll see the management. First is medical management. Bed rest in left lateral position to increase ultra-placental blood flow. Maternal nutritional supplementation with high caloric and protein diets, antioxidant and omega-3 fatty acid arginine. Maternal oxygen therapy should be given to the patient. Administration of 55% of oxygen at the rate of 8 liters per minute round the clock has shown decreased perinatal mortality rate. Next is pharmacological management. We will give the aspirin 1 to 2 mg per body weight. Then labor and delivery. Because of increase of intrapartum asphyxia, the fetus should be monitored carefully and continuously during labor. Delivery should be in a hospital capable of dealing with the various neonatal morbidities associated with growth retardation, including asphyxia, meconium aspiration, sepsis, hypoglycemia, and malformations. Preterm induction of labor is often required. Amniofusion may be of benefit in the presence of non-resonating fetal response. Nursing management. Assess the general condition of the patient, provide proper injection, monitor vital sign, administration of IV should be done properly, provide oxygen therapy to the patient. Next is preterm. A baby born with a gestational age of less than 37 completed weeks is termed as preterm baby. These babies are also termed as immature, born early, or premature. Causes: maternal infection, poor nutritional status, placenta previa, smoking, congenital malformation, multiple pregnancy, overwork, fetal hypoxia, fetal distress, severe cardiac illness, uncontrolled GM, diabetes mellitus, and hypertension. The next is characteristic. Preterm baby is small in size, less than 47 centimeter. The thin pinkish skin appears shiny due to edema. Subcutaneous fat is reduced at buttocks. Weak cry. Then head is large. Sutures are widely separated. Ears are soft and flat with ear cartilage. General activity is poor and neonatal reflexes such as sucking and swallowing are less. These all are the characteristic of the low birth weight babies. Then prevention. Keep all of your prenatal appointments. Detecting potential problems early allows you treat them early. Be aware of your baby's movement. A baby who doesn't move offhand or who stops moving may have a problem. If you notice changes in your baby's movement, call your doctor. Check your medication. Sometimes a medication a mother is taking for another health problem can lead to problems with her unborn babies. Next is complication. Increased incidence of stillbirths, oligohydramnios, meconium aspiration, fetal distress, intrapartum fetal death, lack of glycogen stores may predispose to hypoglycemia. Chronic intrauterine hypoxia may lead to polycythemia. Other metabolic abnormalities. Childhood increases mortality from infectious diseases, congenital anomalies, coronary heart disease, hypertension, diabetes mellitus type 2, and stroke. So these all are the complications of low birth weight babies. Next, we will see about the health education. In health education, we have to provide proper medication, proper advise the mother to provide proper rest to the baby, proper feeding to the baby, and to give the kangaroo mother care and maintain the skin to skin contact to the baby. So this all are the health education we have to provide to the mother and their families. After that, we will conclude. The topic: bibliography. Thank you.